is designed to support local mental health boards or commissions in their functions at the local level and support increased capacity of the local mental health boards and commissions to develop a statewide local mental health board commission vehicle for self-advocacy. Topics that will be covered include recovery and also motivational interviewing. This is recovery from mental health and substance use and motivational interviewing. I am Keris, Myrick, and I will be joined by Kristen, Dempsey, who will talk about motivational interviewing, and today also Camille Duria, who will assist with moderation as well. I am currently the CEO of Project Return Peer Support Network and the president of the NAMI National Board of Directors. I've served on a number of boards and conducted board, mental health system, and services training throughout California and the nation, and my background is in business, nonprofit education, and organizational development. So at this time, let's begin the presentation. All right, so we're going to start first, get to the right place. With just talking about what is recovery and getting us acclimated to what is recovery. I'm trying to get the slide to advance. There we go. So basically, a lot of times we say, well, what is this thing called recovery anyway? What does it actually mean? So I'm going to first start and ask a polling question. Oops. Sorry, I'm getting the screen to work correctly. My polling question next. When I advanced it, it wasn't on the screen. Hold on a second. Okay, I'll go ahead. All right, so I'm just going to ask you to answer a few questions, and the polling questions are these. Recovery from mental illness is possible for some people, no one, everyone, or number 4, I'm not sure. Anybody want to take a gander? Kim, what do you think?
Well, I think some kind of recovery is possible for everyone.
For everyone? Okay.
That's my opinion.
Yeah.
I'm in total agreement.
Total for everyone? Okay. So what is our poll? People are taking the poll?
Haven't voted yet.
Okay, so folks who are online, if you have the ability to vote into the poll, you can vote now.
Tricia said everyone.
Okay. I'm going to go ahead and close the poll. Let's close the poll.
We're back. Go ahead.
Okay, so we think possibly everybody can recover. Some people say, you know, when I've asked this question before, you get different answers. And I think sometimes we're getting different answers because people may be defining recovery different. They may have different experiences with recovery. Or sometimes the conceptualization, definitions, and the services and supports that people are receiving may impact how they're understanding recovery. So let's take a look at this picture. And what I usually do with this slide is I ask people to do a little storytelling with me and to think about what happened to this person and when they might have known that they actually had a problem. So they've already are working on their recovery of fixing a broken leg. So maybe something happened beforehand. What could have happened beforehand that indicated to them that their leg was broken? You can conjecture because I don't know what happened. I don't know this person and what happened to their leg.
They had a car accident.
They had a car accident and they broke their leg. So how did they know it was broken when they had the accident? What do you think that felt like?
It really hurt.
It really hurt.
And they couldn't walk.
And they couldn't walk. Okay, so they couldn't walk. It really hurt. And for folks who are on the phone, you can type in answers, and we'll read them out loud. So they were in a car accident. They broke their... Sorry?
Oh, I'm sorry. I was going to say, I bet they fell skiing.
Oh, they fell skiing. So how do they know that they hurt their leg when they fell skiing?
They knew immediately.
They knew immediately. How did they know immediately?
Very much pain. They couldn't get up.
Okay, so we've got pain. You can't get up. So what's the next step? What do you think happens after that?
They yell for help.
You yell for help. So they're yelling for help, okay. And then do they go to the hospital? Somehow they get to the hospital to get the cast?
Yeah, it's all pretty quick.
It's all pretty quick, okay. So once they get the cast on, is the cast part of the recovery and healing process?
Sure.
Sure, okay. What else do you think is part of the recovery and healing process? What do you notice? What else do you notice in the picture?
Rest.
Rest, okay.
A lot of friends.
They have a lot of friends. How do you know they have a lot of friends?
Because they signed the cast and made it all pretty.
So they signed the cast, they made it pretty, so they have friends, possibly support. And what happens when the cast comes off? Do you think the person might have a little bit of a limp, or do you think their leg is back to 100% the way that it was before?
No, I'll probably have some physical therapy.
Some physical therapy? Okay. What else? Do you think maybe when it rains they can feel when it's, that's what I've heard from people who've broken a bone. I can feel when it's going to rain, my leg starts to hurt, and I broke it in 1992 or something like that. So they're after effects of breaking their leg. So that's a little bit of maybe what a recovery and healing process looks from what would be considered something physical, something traumatic that happened to a person. So let's look at something like this, if I can get this to work. Thank you. Okay, so now we're going to look at what does recovery look like for something that's considered quote-unquote chronic, like diabetes. So what does recovery look like in this situation? Person is taking insulin, is that correct? That's kind of what the bottle looks like there. What else might a person do in their process of recovery related to having diabetes?
Well, they should probably adjust their diet.
Adjust diet, okay. Exercise maybe, okay. Maybe there's medication, diet, exercise. Do you think they're visiting a doctor? Okay. And how are they maybe monitoring their symptoms?
Checking their blood sugar, if that's part of the protocol.
Okay, checking their blood sugar. Are they checking anything else?
Their weight size and body weight.
Weight.
And Denise actually said encouragement, and Eve said daily awareness.
Daily awareness and encouragement, thank you. And do people who have diabetes, there's sometimes they have times when they're not doing well, they're doing fine, and then all of a sudden they're not doing well, their blood sugar changes, and they may have to go to the hospital or other things happen? Is that kind of what happens? Yeah, all right. So that can happen as well. So here, you know, we have a chronic illness that one is managing with medication, diet, exercise, encouragement, support, visits to the doctor, daily maintenance. The quote-unquote illness may be episodic, meaning they're doing well, and then maybe they're not doing well, and so forth. So I think that gives you some idea before we even get into mental health recovery and healing. How do you think about it relative to other types of things that can affect people, from physical things to chronic illnesses? And also, what can happen, and this is just human nature, is a response to an event where you're either sick or you've broken something or you have a physical ailment, is it could be the starting process or point of activation when a person says, yeah, you know, I knew I could fix it on my own. And they're really trying to identify what can they do on their own in order to fix their broken heart, for example, or, you know, fix some kind of illness or ailment that they have. So now let's talk about mental health recovery. And I'm just going to ask people to think about this for a second and to fill in the blank. Truthfully, there's no one right answer. Just like you to think about, what does mental health recovery mean to you, and how would you finish this sentence? I'll give you a few minutes to do that. All right, so mental health recovery is. I know I have someone who's answered on the phone, and their response is?
Patricia said being able to function like other people.
Mental health recovery is being able to function like other people. What else?
Dennis said making life changes.
Making life changes. Recovery, mental health recovery is making life changes. Okay. Any responses in the, oops, more.
Louise, sorry if I'm mispronouncing your name, said ongoing process.
Mental health recovery is an ongoing process. Great. Wow, these are really good responses.
And Eve said staying productive.
Mental health recovery is staying productive. Great.
I think mental health recovery is feeling part of the world, part of the world that's around you.
Mental health recovery is being part of the world that's around you. Okay. These are great. So let's move on. So I always, when I talk about mental health recovery or do training about mental health recovery in all different kinds of audiences, from providers, family members, community folks, just people out in the community, schools, and so forth, people always talk about it as being somewhat complex or not really understanding what it is when we're talking about mental health and substance use recovery. And sometimes it may be because the process of recovery can be a bit elusive because it's so fundamental. Anytime you get sick, the first thing you think about when you get a cold is, how do I get over this cold so I can get back to doing what I want to do? It's the most common experience that we can talk about for everyone to start this thought process of change and transformation that these caterpillars and pupas do to become beautiful butterflies. It's a transformation process. It's also profoundly individual, and individual can sometimes add complexity. But even within complexity, there are patterns and processes that may be somewhat similar across individuals. And so we'll talk about a little bit more, again, about what that looks like. So our ideas about recovery, especially for mental illness and mental health, let's look back to the early 1900s when Emil Kraepelin, who's a German psychiatrist, talked about the disease and the diseases caused by biological and genetic disorders. And he called these syndromes, which meant there was a common pattern amongst the symptoms. And so dementia praecox, was one of these. It was really kind of a precursor to what would have been called a mental illness, usually schizophrenia. And he defined it as having an irreversible mental decline. I mean, when you read something like that, the idea of recovery is almost an oxymoron. It's like, how could it happen if it's irreversible? You can't recover if you can't reverse something that's happened. And one of his contemporaries, who came just a little bit after, was Eugene Bleuler, who was a Swiss psychiatrist. And he actually did think that people were able to recover and function, quote unquote, normally, but just for brief periods of time. And he saw this due to brain or abnormality rather than total brain degeneration. And I think he actually coined the term schizophrenia, which meant well, it really means at the time split mind, and that's why sometimes people confuse schizophrenia with split personality. Of course, we know that's not quite the same. But again, you sort of read this and you wonder, well, what does this mean about recovery? You can only do it for little pieces of time, and other times, you're not able to be in recovery. So Pat Deegan, who many people know, who works a lot on shared decision-making, she's a leading mental health researcher and also a person with lived experience. She said once, it is inertia which paralyzes the will to do and to accomplish because there is no hope. It is being truly disabled, not by disease or injury, but by despair. I think before we go any further, it's really important that we start with a basic fundamental concept, and that is one of hope. That it's very difficult to move forward in recovery if people don't have hope or if there isn't a belief in hope. And so I'm going to ask people to think about something really quickly. In order to know hope, I call it, I think we're going to take a moment and get to know what this means, this idea of hope. I'd like everybody to take about just a minute or two and think about some dream or goal that they would like to accomplish in the next, let's say the next 5 years. So pick one, only one, dream or goal that you would like to accomplish in the next 5 years. And if you don't mind sharing that, you could, for folks who are on the phone and on the webinar, if you could type your dream or goal in the question box, that'd be great.
Patricia said having a home near the ocean or a beach.
Ooh, okay. Having a home near ocean or beach.
Carl said to be a functioning person.
To be a functioning person.
David said finish building more Annapolis Wherry rowboat. I don't know what that means. Sorry. Annapolis Wherry rowboat.
Okay.
Increase mental health services in our schools in Shasta County, and that's from Marcia.
Mm-hmm.
Dennis said decrease homelessness.
Mm-hmm. So decrease homelessness, build more mental health services in schools, build a particular type of boat that we're not quite sure what it is. But that's okay, the person does, that's their dream. To have a house near the ocean, to be a fully functioning, is that what the person said, to be? What was the other one?
A full functioning person.
To be a full functioning person.
And then Eve said, I want to start a unique nonprofit for peers by peers.
To start a unique nonprofit for peers by peers. What else? Does anybody else have any?
I want to find a way to spend more time back in New York City.
Spend more time in New York City.
Yes.
That would be one for you.
Well, I have a damaged shoulder, looking forward to rotator cuff surgery in the immediate future, and I hope, like you say, dream, to get back to where I was with that ability and use of that shoulder, hopefully within a year.
Okay. So rotator cuff surgery and then the recovery so that it can get back to not having that injurious pain and so forth. Okay, within a year. So these are great. These are people's personal dreams and goals and hopes. And what can happen in the mental health community? Well, yeah, when we come into mental health services, just imagine this, especially for young people. You come in and the messages that we receive are things like, oh, you're not going to be able to work anymore. Oh, you're not going to be able to go to school. No, 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 you really need to focus on those symptoms. Oh, no, no stress. There cannot be any stress in your life. Living independently, well, we'll see. Let's put you on disability first. You're always going to need treatment and meds, by the way. And, yeah, well, let's just see what kind of happens. So all of those lovely dreams and goals that you all talked about can sometimes be dashed immediately when a person walks in to get services. So our goal, I would think, is to have a better understanding of the impact of those messages, turning those messages into something positive and hopeful, and helping people to achieve their dream no matter where they are in the midst of their recovery from mental illness. So let's look at the next slide. So now we have some new thoughts about, is recovery possible? And within the substance use field, the first known book about recovery and addictions, of course, is Alcoholics Anonymous. And within the mental health field, we hear a lot about Clifford Beers in a book called A Mind That Found Itself. And for folks who don't know who Clifford Beers is, he published the book A Mind That Found Itself in 1908. And he was a person who was living with a mental illness. Actually, everybody in his family was. He had 4 other siblings who also lived with mental illness and received treatment throughout their life within institutional settings. And he himself wrote this book after being in a psychiatric hospital and state hospital and saw the injustices and mistreatment there. And then in 1909, he actually founded the National Committee for Mental Health Hygiene, which is now called Mental Health America. So I think many of you know what Mental Health America is. And so he's what we would probably call one of the first leaders in mental health system transformation. The second person is Judy Chamberlain, who's one of the first contemporary consumers to write about recovery. In her book, On Our Own, Patient-Controlled Alternatives to the Mental Health System, and then subsequently she wrote for the National Disabilities Coalition, From Privilege to Right, and was a recipient of a President's Medal of Honor. And she is a leader in the psychiatric survivor movement that we know today as the consumer movement or consumer survivor peer movement. So these are some of the first people who are writing about their personal journeys and stories to give hope and promise of recovery as they understood it in their lives. So I think we've come a long way from the days of Bleuler. Oops, do we have a question? Sorry.
Denise wants to know on the dates, was it 1908 or 1980?
For who? So I'll just tell you. I'll just go back and tell you. So Clifford Beers published his book, A Mind That Found Itself, in 1908. And then Judy Chamberlain published her book, On Our Own, in 1978. And now I bet if you, I should do this one day. If you Googled first-person recovery stories, you would find a gazillion. So I think more and more people are actually talking about their recovery and writing about it. People like Ellen Sachs and Joe Rogers, Susan Rogers, and just a number of people who now are writing about their recovery journey. So now let's look at what's going on in the 80s. In the 80s, we have the 1980, let's say, the DSM-3. And in the DSM-3, talks about the common course of recovery from schizophrenia as a common course of increasing residual impairment episodes, which means basically there's kind of this idea of recovery is kind of on and off and on and off, but over time you're really not going to do very well. And then in 2000, you think we're kind of speeding it up there. In 2000, in the DSM-4R, under schizophrenia, it says the long-term outcome, it appears that some have a relatively stable course where others show a progressive worsening associated with severe disability. So in some ways we've come a long way, and in some ways there's still a little bit of work that we have to do to have a better understanding of how recovery works for people who not are just diagnosed with schizophrenia, but any mental illness at any point in their journey. So let's look at some definitions of recovery. So this one was published in 2004, but it took about 5 years for them to come to a consensus about what the statement would actually be. And this statement comes from SAMHSA, and SAMHSA brought together about 80 different stakeholders, from family members, people living with mental health issues, and providers. And they came up with this statement: mental health recovery is a journey of healing and transformation, enabling a person with a mental health problem to live a meaningful life in community of his or her choice while striving to achieve his or her full potential. And the essential components to achieve that definition, there were these 10 essential components, which are hope, which we've talked about, self-direction, which is about choice and being able to make some choices and decisions about what you want to do in your life, individualized and person-centered, so the treatment is individualized and centered on the person who's receiving treatment, that they're empowered and empowerment, holistic, taking care of the whole person, non-linear, which means really understanding that mental health recovery can have its ups and downs, its backs and forths, and it is not a straight it doesn't necessarily have to be sort of a straight trajectory towards illness and wellness, that it's strength-based. So now here we're focusing on a person's strengths versus the weaknesses that they have, and using those strengths to aid in their recovery. Involves peer support, respect, and responsibility. A lot of people have been using this statement for quite some time until we started to try to measure recovery. And that statement made it a little difficult for folks to figure out, well, how do we measure recovery and that recovery is really happening? So in 2011, SAMHSA came out with another, what they called a working definition. And the idea of the working definition, again, that was put together by consensus in a group of people with lived experience, stakeholders. They actually put the definition out to the broader public so people could give information online and give feedback online. And it is now a working definition that states recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And these are the 4 areas that support a life in recovery. So health, of overcoming or managing one's diseases as well as living in a physically and emotionally healthy way. Home, a stable and safe place to live. Purpose, meaningful daily activities such as job, school, volunteerism, family, caretaking, creative endeavors, and the independence, income, and resources to participate in society. And then the 4th dimension is community, relationships and social networks that provide support, friendship, love, and hope. And I think in a role as on a commission or a board, that when you're looking at your systems and evaluating your systems, are you looking for things that actually impact these 4 dimensions to aid in the people who are receiving services, to aid in their recovery? Are there connections to, for example, home, a stable and safe place to live? Purpose, are there opportunities for job, supported employment, supported housing, supported education, volunteerism, family involvement, so forth? So these might be some of the things as you're doing maybe program or system evaluation that you would be looking to see, do these things exist in order to know whether or not the system in itself is providing recovery-oriented supports. So let's look at a couple of other things related to mental health recovery.
You want to do the poll?
Oh, yeah. Oh, I have a poll. So now I'm going to ask you to answer this next question, and it's a poll. So for those who are on the webinar, they can do this on their computers. So the poll is, recovery happens when? 1, it happens 1, after a diagnosis. 2, when a person is engaged in treatment. 3, when a person is quote-unquote stable. Or 4, at any point when a person identifies being in distress.
23% said when a person is engaged in treatment. 31% said when a person is stable. 46% said at any point when a person identifies being in distress.
All right. So what do you all think in the audience? Do you think it's 1, 2, 3, 4?
I would
1 is after diagnosis, 2 when a person is engaged in treatment, 3 when a person is stable, 4 at any point when a person identifies as being in distress.
I think I would say
4.
And Carl said at any point.
At any point. Okay.
And then Patricia said at any point of distress. Dennis said at any point.
At any point. Okay. So I don't know if I'm going to give a right answer. So let's see what we think about recovery after we look at a few more slides and get a little bit more information. So before recovery, as I said, a person can come into the mental health system. They can come even talk to a family member or a friend and identify as having some distress and may be diagnosed with mental illness and are receiving professional care. Generally, when a person comes in and they're identifying as not feeling well or having a tough time, they're also talking about those other things that impact their life that are very similar to what the SAMHSA statement has covered, such as work, social relationships, education, spirituality, family, other types of relationships, and community. So we see very often someone may come in and they may be talking about disturbances that they're having in school, or even a family member may bring in a youngster, one of their children or teenagers, and talk about disturbances that are happening in their education. They're not able to concentrate, they can't sit still, they're quote-unquote disruptive in class, and so forth. And these are sort of the overarching things that are going on, but what becomes the center of attention is the illness and the care. And there really isn't much talk about how do you help that person stay connected to education, or how do you help the person who identifies as, well, I was working, or I was working, became very ill, and the focus then becomes largely on the illness and the professional care. It's almost like it's a little out of, not out of context, but definitely it's taking up a really, really huge sort of portion of the person's life. All that other stuff is moved to the side. Let's get the symptoms down, and then we'll talk about all this other stuff. Well, recovery looks a little bit more like this. So the person is identifying maybe having some problems with work or family, or they're not getting along socially, they don't have any friends, they're lonely, they're isolating, people in the community, they're not involved in their community or included in their community, their education has stopped. As we know, many people who are diagnosed with schizophrenia or bipolar disorder generally can happen during a critical point in their education. They're no longer engaged in spirituality, or quote-unquote could be overly identified with spirituality. And but all of that is going on while there is mental illness and professional care. You can see that the circles are still there. And generally, when you're talking about a life view with recovery, you're still in the midst of your illness and receiving professional care, but the focus is on the thing that you identified as having meaning and purpose, back to that SAMHSA statement. So for example, if family is really important to you and your family is sort of self-destructing, because of the things that are going on with your mental illness, you may be talking a lot about your family, and the professional may be talking about, well, you need to get the symptoms down, or it's important to take your medication, or so forth. But you keep talking about the family. So it's important at that point that the conversation also include your concerns about the family. And that's kind of what recovery looks like. It's all of these things happening at the same time, rather than moving all of those important social aspects to the side and focusing on mental illness alone. So the research tells us a little bit about what recovery looks like. Dr. Courtney Harding did a study in Vermont in 1978. It was one of the first longitudinal studies of people who were in recovery. And she has a very, for this research, the criteria for recovery is really, really stringent. So it's having a social life that's indistinguishable from your neighbor, holding a job for pay or volunteering, being symptom-free, and being off medication. So even the SAMHSA definition doesn't say you have to do all of that in order to be considered in recovery or a part of recovery from mental illness. So she had a sample size of 269, and she followed folks who were released or discharged from the back wards of the state psychiatric hospital. And she found over the years, I think it was over a 15-year study or 20-year study, that 62% to 68%, according to the criteria that she listed, actually were fully recovered. So if you look also at the research outcomes of other studies, whoops, there we go. So we have other studies that were done that were longitudinal studies, and you can see the average number of years of the study. And this is a different Blue Alert that you're looking at in 1972, probably the grandson or granddaughter of the Blue Alert that we're talking about in the early 1900s. But anyway, so he did a study for, and the average length of years is 23 years that he followed people over time, a sample size of 208, and they found that 53 to 68% were recovered or improved significantly. So as you look at the studies that continue on down from 1972, 75, 76, 79, Harding is 1987, all the way to 1995, you'll see very high levels of recovery. So important concepts. So I think we're finding that everyone has the capacity to recover. And recovery is a journey, and it's a process that involves self-education and self-determination. And emphasis is on peer support and working to reclaim your chosen life. So there are tools that people will use, such as Wellness Recovery Action Plan. Medication can be part of a tool. Whole health action management, seeing their psychiatrist, working with a social worker. Like for myself, I identify work as my tool for recovery. If I'm not working, I tend to not do very well, which is interesting. And I was once told, oh, you've got to stop work. And I kept saying, no, if I'm not working, I'm not really going to be my best. And that actually proved to be quite true. I was on disability. I was actually at my worst and couldn't get better until I really said, I got to get back to work, and I was supported to get back to work. Recovery is a journey. It's always in process, and we all have the capacity to recover. So here's some core elements of recovery. Again, we can see this, how it matches with the SAMHSA statement of establishing a secure base, such as housing, income, safety, health care, forming supportive relationships, friends, family, and community, empowering yourself and asserting self-determination. What does that look like, do you think? I'm just going to ask the question and people can type in. When you have to assert self-determination or empower yourself in order to achieve recovery, what might that look like? I know, I threw out a question.
I would say those are all really important.
What would a system have in it? What do you think a system or a county or would have, what would it look like if it were a recovery-oriented system?
I think it would be, I think there would be supportive relationships between systems in a county, and in terms of, sometimes we feel like consumers receive maybe fragmented services, and I think maybe feel like there's some understanding of a connectedness there in
Okay.
And Patricia said, taking care of my needs, such as income and being on my own without any help from other people.
Okay.
Janet said, respect calling by surname, not assuming first name automatically.
Okay.
David, frightening requires a huge decision, challenging in the extreme when first attempted.
Okay, so sometimes trying to assert your self-determination can be frightening and challenging and scary. Okay. All right. Any other thoughts about what go ahead.
Dennis said affirmation of belief in self and others.
An affirmation of belief in self and others. So when we talk about what this looks like in a system of care, we're talking about a system that is connected or has the ability to connect to the supports and services in order for a person to have a lot of those things related to income and independence and housing. What else would it look like, Terry, as far as a recovery-oriented system?
Maybe that sense of empowerment that one would feel having developed coping mechanisms within the environment that they're living in. I think that going through that period of stability can build strength mechanisms that were not there before. So I see the possibility of coming out stronger because of stresses that are created and that you get through. I don't think you can ever get back to where it was. Everything changes over time. So I don't really like saying recovery, but I can't offer you a better word right now. So.
Okay. So in the process of recovery, it sounds like you're talking about building resiliency and using that resiliency to move forward with a life that now you're claiming versus trying to reclaim a life maybe that was before sometimes. So that perhaps, and then again, I'm putting words in your mouth maybe, so you can correct me if I'm wrong, but I heard you kind of talk about, when you're going through a lot of stressors, you're creating these coping mechanisms, and those coping mechanisms build strength in you to move forward. And even how you are yesterday may be very different than how you are tomorrow or a year from now, especially when you're building resiliency from recovering from a mental illness.
It's growing, and you really become empowered when you look at that. That's what I think. That's my experience.
Oh, yeah, very cool. Yeah, I never really, the recovery thing, so sometimes I like to use the word healing, that a person is healing over time, because healing means that you're getting better over time, all the time, but it doesn't necessarily mean you're going back to that place of where you were before. Yeah, and I think almost human nature, we're always changing and evolving and growing. So do we ever go back to who we were before at any point? So it really makes what we're doing, I think, and what we're talking about much more humanistic than worrying about is it related to, quote, unquote, a disease. This is what humans go through. They go through trauma, they go through pain, they go through distress, and through that coping mechanisms and overcoming that stress, they build resiliency and strength and growth. So, any comments? Okay, let's move on. Thank you. All right, so I love this. I'm right there in the room and no one acknowledges me. What do they call that, the elephant in the room? Okay, so the elephant in the room sometimes, especially in a treatment setting, can sometimes be that thing that I was talking about, sort of the person receiving treatment, talking about housing or those purposeful things in their life, that meaning and purpose in their life, while the doctor, and I'm not painting psychiatrists by any stretch of the imagination as people who aren't listening, but even peer providers sometimes, we're not listening very well. And we have to listen to exactly what it is a person is identifying as the area that they would like support in improving. My family, my relationships, my work, and that's what really person-centered care is all about. and a vital part of what a system needs in order to help people recover. So in our relationships, things can happen. Wow, is it time yet? I've been talking here, sharing everything, or somebody sharing everything, and I'm a little on the bored side. And the person is like, wow, that person's a clock watcher. What's up with that? They're really not paying attention. They're going on and they're talking and they're listening, and kind of like a yada 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 moment. And the person is really thinking about something else. They're not even really present. Sometimes people think, oh, wow, that person's really being manipulative. While the recipient of service is also thinking, wow, that provider is really manipulative. So both sides of the equation can be thinking about who's trying to manipulate who here. And what we're trying to get to is people who are providing services in a humbling way and thanking people for sharing the most intimate details of their life and sharing that they really care. And knowing that folks are present for you. So what are some of the obstacles to providing recovery-oriented services? And I think these, again, are things that, on the local boards and commission, things to be mindful of when you're reviewing any type of evaluation or looking at what folks want. The provider can have limited time. They could have overly busy caseload. They may be thinking about liability. A lot of us, even in the peer community and our peer services, a lot of times it's like, how much risk are we willing to take to help someone? So we have to think about liability, where audits, so Department of Mental Health and financial audits, all the paperwork that comes with that, and now we're moving to electronic systems, and insurance and billing. At the end of the day, and all the system navigation. So all of these things can get in the way of really doing what a lot of people come into this work to do, which is to be present, to be welcoming and hopeful for folks. But at the end of the day, if we have all of these things that we have to contend with, you may have a very unhappy client. So when we look at what that may look like in a quote-unquote disease-centered model, and again, here's where you might be looking at, again, what does the system of care and agency look like, are the roles of the professionals. And I also consider peers to be professionals, in that, and family advocates, for example, or parent partners to be a part of the professional role, is that we also have to be mindful of this and careful about this, about whether or not our role is hierarchical, paternal, we're in charge, we hold the important knowledge, the professionals, we're responsible for the treatment. By the way, we've got to focus on that disease. Where the patient's role in this model is, okay, so I'm subservient, obedient, I'm passive, I receive all of your knowledge, I have to follow your treatment, I'm responsible for that, and I am actually the host of the disease. So this doesn't look at strength-based. I think it takes a lot away from this idea of self-determination and empowerment, and also being knowledgeable about your own body and your own self related to what's going on with you. So we're, again, talking now about a person-centered care. What does person-centered care and a person-centered model look like? So now the person, and the person here is the person receiving services, has personal power, they have personal knowledge and responsibility. Everything related to what's going on is in the context of their life, and that's the focus. The person is self-determining. And in the professional role, we're sharing power, exchanging information, we're co-investigator, and we're an expert consultant on the journey, and there's involvement in shared decision-making. People sometimes ask, well, how can people do this who are quote-unquote very, very ill? For example, if someone is coming into services through like an FSP and they're homeless, can they have personal power, knowledge, responsibility, and be self-determining? And within a system and within the professional role is to give that person as much power, knowledge, responsible decision-making, self-determination, autonomy, and empowerment as possible, even no matter where they are relative to their particular situation when they come in and meet with you. Share as much decision-making as you can. I'm looking at the strength and resiliency that a person brings. And I always am, very, very conscious and humbled by the amount of experience folks who come to us receiving services who are without housing. The level of resiliency, the level of problem solving that one has to do to manage day to day when you're trying to meet your basic needs. And that's a huge strength that they can use in their recovery from mental illness and or substance use. So I can take some questions now. This is a gate at the City of Hope that says, I can't read it, so I now have to find my slide that actually says what it says. But let's see what it actually says. So it says there is no profit in curing the body if in the process we destroy the soul. And that really is, I would hope, what we're all trying to do is ensuring that we're working with mind, body, soul, and spirit in recovery. So I could take some questions for a few moments if there are any. No? Okay. So why don't we take a 3-minute break, and we're going to switch out from me being the facilitator and trainer to Kristen Dempsey. So let's just take a 3-minute break. Okay, so welcome back. I'd like to introduce you to our next trainer, who is Kristen Dempsey, and she's a marriage and family therapist and most recently worked as Director of Workforce Development at San Mateo County Behavioral Health and Recovery Services. So she's going to talk to us about motivational interviewing. She is a member of the Motivational Interviewing Network of Trainers and is a trainer for applied suicide intervention skills and training. So, Kristen, you want to go ahead and start?
Yes, thank you very much. Can everyone hear me okay? Hearing that.
Yes, we can hear you in the room.
Excellent. Okay, as long as everyone can hear me, I will get started. Well, thank you very much for being here on this Saturday morning. I am going to be speaking about motivational interviewing, which I will call MI, and I am realizing oops, there we go. I have to press hard. Here we go. I am a member of the Motivational Interviewing Network of Trainers. There's a few thousand of us throughout the world. And motivational interviewing, which I will refer to as MI, is an approach that is really, it's been very effective cross-culturally, which is why it's actually been used in over probably a few dozen countries. It's been translated in over 40 different languages throughout the world. And it's being used increasingly in behavioral health care settings. And thinking about folks being on boards and commissions, what I'm hoping to do today is to give you enough information about motivational interviewing to really feel like you can make some thoughtful choices about motivational interviewing maybe for your particular boards, and to really think about the intervention and how it might be used. I'll be talking a lot today about substance abuse and the use of motivational interviewing in terms of treating addictions or substance use conditions. And that's where it started. It started out of the University of New Mexico. You may hear me others refer to Bill Miller and Stephen Rolnick. They're actually the developers of motivational interviewing. I will pause at times to make sure you have an opportunity to ask questions. If you have any other thoughts, please, by all means, type in your questions, even while I'm talking. And I have many more slides than we could ever really go through in an hour and a half, for instance, or an hour, actually. And I do know that. So what I've done is I've left in some extra slides that you can review afterwards, because I think it's helpful to have the slides. Some slides I'll go through more quickly than others, just to keep us on track and to make sure you get as much really helpful information as you can have. So I want to start here because this is a really wonderful place to start after Keris's presentation, which was really terrific about recovery. And thinking about, what's working, what's not working in terms of some of our current models and how people communicate. What is really wonderful about motivational interviewing and why it's been adopted not just in behavioral health care, not just by substance use professionals, but people working in mental health, people in probation, people in primary care, people in schools even, is because it's really effective. And part of what makes it really effective is that it really allows people to have kind of genuine, functional interactions with each other. And if we're thinking of part of what we were just talking about is defining what is recovery, motivational interviewing really helps us think about the how. How might we do this? If we want to really be in a place where we're not thinking people are manipulative and we're engaged with them and the elephant in the room is being heard, how might that look? So here's a real basic definition. You can find a lot of definitions, and at the back of your handout, you actually have some of the newest literature. This is from the third and most recent edition of the Motivational Interviewing Handbook, which is actually a great read. Not all books about different types of interventions are very interesting. Some of them are 300-page sleeping pills. This one actually is a really great readable book, and no one's paying me to say that. It's a really excellent way of organizing all this information, and they have a lot of definitions, but I like this one because it's the most basic. A couple of things you'll notice, and again, please type in some of your comments as you're noticing things as well, is it's collaborative, and it's about a conversational style. Dr. Miller wished he would have called it motivational conversation instead of motivational interviewing, because the difference between a conversation and an interview, a conversation is more egalitarian, whereas an interview is very much top-down. It's about working with somebody instead of to somebody or for somebody or against somebody. And it's really looking at somebody's own motivation and helping to build some commitment and movement towards change. Because people, when they're recovering, as Keris pointed out, they're in a change process, and we're always constantly changing. And we want to join somebody where they want to start, because that's actually where the energy is. So I'll have a couple more slides, and I'll entertain some questions. So motivational interviewing is, we guide people. We don't tell them what to do. We're not super directive. We're not Dr. Phil type folks. And we also don't just sit passively and listen and don't provide any assistance. It's a real art. It's an art of listening to somebody carefully and with huge amounts of respect and helping them be guided toward health. It's also about working with ambivalence. Ambivalence has gotten a bad name. People think ambivalence is terrible and people are stuck and they can't move. Often when we feel ambivalent, it's really uncomfortable. But when someone's ambivalent, it's actually normal, and that's actually part of the change process. Think about some tough changes you've had to make. Maybe you're making now. Do you ever feel two ways about something? Are choices easy to make? And I bet if you're sitting there thinking about this, you can probably pretty honestly say you've had some real struggles at times. What we've also learned, and those of you who've ever had teenagers, you really know this piece, is that the more we try to direct and argue for change, and I'm talking about this from a therapist perspective, but certainly, again, you can think of it from a boss perspective or from a leadership perspective or a parent, the more we often get people pushing back. So we may think that we're right, and maybe we are right, but we're not effective. Motivational interviewing is really trying to work with people's own energy. We also want to get people to talk a lot in MI, the people that we're working with, because when people talk and they hear themselves talk, they persuade themselves to change. I'll stop here just for a second. Are there any questions about the definition or anything that I've been saying?
You can continue, Kristen.
I can continue, thank you. So with motivational interviewing, there's actually two things we're doing. We're working with the spirit, and we're also learning skills. And thinking about this from where motivational interviewing came from, especially around substance use treatment, that often, there was a sense that people come in and we needed to give people a haircut. And I mean that metaphorically, of course, sometimes literally, that we really need to get in their face, need to confront them, tell them what's up, because if people were in denial, they were resistant, they didn't really want to change, and we had to pull them out of that place. And one of the things that Dr. Miller got really curious about is when he looked at people he worked with in the addictions field, he noticed that there were a lot of people who had a lot of similarities. But some people got sober and other people didn't, and what was the difference between the path? And he started to really notice that people started to change and be motivated not so much when they were told what to do, although clearly some people that's what they want, and if that's what people want, well, we can do that for them. We can collaborate with them. But there were a lot of people who had no choice, and that when confronted in a way that was really strong, maybe it feels really disrespectful, and it's more about hierarchy, that people, like I said before, push back, and people don't come back. So we lose a lot of people to the healthcare world who just don't want to come back because of that type of attitude. So the spirit of MI is really a spirit of humbleness and of respect. And even though that sounds kind of simple, a lot of people, especially people trained in some of our more traditional treatment models and medical models, really have to learn this or relearn this. I also am a faculty member at a couple of graduate programs, and what I tell my students is, don't let all this clinical training cause you to lose your humanity. Mainly because if you get all this clinical training and you lose your humanity, you're not going to be very effective, not to mention the fact that, why did you come into this field? There's a lot of levels of interest, and MI as a spirit really allows us to treat people as we think they can be, to really focus on their potential as opposed to treating him as he is, seeing somebody maybe in a really tough place and thinking that they can't go anywhere further. So that helps to kind of really guide our approach. So again, this idea of there's something we do with people, and that ambivalence is normal, and that we're looking at the glass being half full. We look at people's strengths, what they have, because we all know the problems when people come in. And again, I'm using addiction as my guide here. We know somebody has a terrible addiction. We know about the consequences and the loss. We certainly will talk about those, and those are in the room, and often they cause a lot of pain. But for people to actually need to change, for people to actually have some change, we need to focus on strengths, because it's our strengths that actually help produce change. We leverage strengths for change. So there's some principles that underlie this idea of spirit. And what is spirit? Well, there's some very core principles around acceptance, collaboration, compassion, and being evocative. And what I mean by that is we accept people for who they are when they come in. Maybe they're really don't want to quit using. Maybe they smell. I mean, not to be mean, but maybe it's uncomfortable being with them. Maybe they aren't very pleasant people. We accept that and think in some ways like, wow, it's amazing they're coming in right now. Here they are. We collaborate. Again, it's about being in partnership as opposed to doing something with somebody. We have compassion in that we are doing this for this person's benefit. I'm not trying to sell them a bill of goods. It's really about the intention of helping that person. And we're evocative. In MI, we want to speak about 20% of the time, and our clientele, consumers, to speak about 80% of the time. We don't have all the solutions and answers. They do, and our job is to guide them and help them find it. So here's something just to get us into the spirit. I don't have polling questions, but I have a couple of interactive things. And think about this, and please, for those of you who'd like, please come back with some answers, either online here or in the room. Think about your favorite teacher or supervisor. What was his or her characteristics that inspired you to learn, to excel, to grow? What was his or her name? What characteristics did he or she have? What inspired you to do your best? And then finally, how did you respond to his or her efforts? Anybody in the room have just a couple of examples, a couple of thoughts? Go ahead, Kim. Kim has a question? Yeah.
I was going to say go back to my the favorite teacher question. Is that what I was thinking back to a teacher that I had in high school who was it was a music teacher, and I just remember that he was so motivating because he was so good at what he did, but he did it. He was very funny and had a great sense of humor, and he taught us in a way that we never really felt like we were working very hard. It's a great outcome.
Okay, great. And probably, I'm assuming that, in that way, because in teaching situations, usually it's like this instructor talks to the student. There's this real roles of difference. And it sounds like he was able to really effectively collaborate with you and be with you in a way that was really evocative of your talents, that really got you to come forth.
Yes.
Okay, nice. It's a nice example. Just being with somebody. And again, for a lot of clinical situations, it's just hard for us sometimes to put back our authority role and just be with somebody, have a conversation. Anything else?
Yeah, Dennis said always positive when bad happens.
Yeah, always positive when bad happens. I think a lot of times that's like a really important piece about acceptance. right? You know, it's like if I have non-acceptance, I can't always be positive when bad things happen. But if I'm able to really hold that hope, as Keris was talking about, and to really be with you, I can accept that you're going to have setbacks. And that's a really important piece about the spirit, is a lot of times, especially historically in drug and alcohol treatment, it's like if people lapsed or relapsed, that was it, you're out of the band. And people sometimes literally would be kicked to the curb, which is one of the worst things we can do for people, because that's part of growth and change is slips. And so, yeah, bad things happen. Okay, we're going to, you know, what did we learn from that? How can we step forward? Nice.
And Kelly said, I have had many great influences in my life. However, the best supervisors/teachers have engaged in active listening.
Yes. And active listening is really an important piece. Here's where, in fact, let me just kind of, perfect. Thank you, Kelly. Perfect timing here, too. I can move this little guy to the next one. Oops, I'm in the wrong place. That's why. There we go. Oh, I don't have it here. I'm sorry. One of the things that we have in terms of the acceptance piece is an ability to show that we're actually listening as well, and that's also part of the collaboration, and it relates to our skills. Acceptance is about being empathic. Collaboration is also being in that way. And so what we're doing, we're actively listening, is that's true empathy. And how do you know if somebody's really listening? Well, they're reflecting back to you. And again, I don't have to stop and judge you or give you advice right now or try to direct you. I can just tolerate and listen to you and have you hear yourself speak. A really huge, important piece about being in the spirit. So thank you. Is there anything else?
That's all. You can move on, Kristen.
Thank you. Okay. So I'm back to motivational interviewing and looking at the actual structure, and this is a helpful piece. In the newest edition of motivational interviewing, we actually have 4 foundational processes, and this makes it really easy to understand and explain and do MI. When I first learned it, we learned the skills, which I'm going to tell you in a few minutes, which was very helpful, but sometimes it was hard not to have a roadmap, and this gives us a roadmap. If you did earlier training in motivational interviewing, we used to talk a lot about the stages of change, if someone was pre-contemplative or contemplative, and basically what we come down to is there's a point when someone comes in where they're not actively changing, and what we do is we get people from non-change or pre-change to change, and that's what we're concerned about. And often, move forward here, we're going through this process. There's 4 steps. So it kind of makes sense, you know, engaging, we're in the process of establishing the helpful connection and a working relationship. That's where the spirit's really important. You know, we're not judging people, not telling them what to do, what they shouldn't do, you know, just, you know, merely providing a prescription or a quick step. We're really listening and hearing and building that collaboration. And as we do that, we're thinking about how to focus. This idea of, okay, you have this and this and this happening, where would you like to start? Because part of being motivated is having a piece of focus. Many times we are so overwhelmed or we're so underwhelmed, you know, we can feel really hopeless and you know, there's nowhere for me to start. I have no idea. That for a clinical person to really help with this idea of, well, let's find a place to get focused, in and of itself is really hope-inducing and motivating. So once we have a piece of focus, we become evocative. And the term they use here is evoking, and I've never seen that in any dictionary. But it's a word we've made up, which is we really elicit the client's own motivations to change as we hear more of their story. So what I'm hearing is you have a lot going on in your life right now. You've had a number of DUIs. Your family's really angry with you. Your kids won't talk to you. You know, all these particular areas, where would you like to focus? Maybe it's, I want to focus on this DUI and getting that finished. Okay, so tell me more about this DUI. What was happening? So as you can see, I take all the stuff someone might bring in, get them a place to focus, and then say, tell me more. Now, you may have noticed there that I didn't say, well, you need to focus on quitting drinking. That's your real problem. If you just stopped drinking, you wouldn't have the DUIs. Again, I might be right, but I won't be effective necessarily if it's not his or her decision. Now, as we talk about the DUI and we get more of the story, inevitably what's going to come up is their drinking pattern. And they still may not be ready to quit drinking at the end of that session, but what we're doing, what I'm doing, is what I call developing an itchy sweater. The more they talk about it and the more they talk about the consequences just in their storytelling, the more that behavior becomes uncomfortable. Because people grow, and they grow after they leave me, and they're going to grow more as they progress from day to day. And if I leave them with something that's a discrepancy between what they're doing and their values, that's a great way to build motivation. And finally, and I'll take some questions here, at the end of this, after someone has given us a lot of maybe reasons to change and we're exploring all the stuff going on in their life, I might summarize all this. I might say something like, wow, so with this DUI, you've lost a lot. You've had these fines. You have to come here for this mandated counseling. Your wife won't talk to you. It's hard for you to get to work, and you have embarrassment of being in jail. So I'm wondering, where does that leave you? What might be your next step? And as I do that kind of recapitulation and summarize, I ask that key question to be really strategic around what might be the next thing that you do. And so with these 4 processes, it really helps us organize what it is that we're doing. And here's the important piece to always remember. If you want to circle a slide on your slide set, kind of the most important place to really come to when you think about MI, think about this. Everyone is motivated towards something, and you start with that action is. And when they're not yet in action, you're curious about. You have them talk about it. This idea of equipoise is we listen to the reasons that they want to do this, and then we listen to their reasons they don't want to do this. We don't try to influence that. We don't say, yeah, okay, you like drinking, but you really, we really need to quit. Like, okay, we're going to listen to those reasons for what they like, and then we'll gradually bring up maybe the not so good things. So it's all about balance. Because again, if we push too soon, we get somebody to push on back. So given this, I'm curious if there's any questions right now or any comments. Okay, so hearing none, I'm going to move up to this piece of change talk. Some of you who are doing this work might have some familiarity with change talk. And when someone comes in and they're talking about their lives, and they're talking about the status quo. Oops. Can you hear me?
Yes, we can hear you.
Okay. I'm having a little problem here. Unfortunately, with of course, it has to happen right now, my phone, so I might change phones here in a second, but at this moment, I'm doing okay. This idea of status quo, it may be, sometimes we call them names. We call them resistant, difficult, a piece of work, all of these particular things that we might call somebody. And that's really common, especially in substance abuse treatment even, if you can believe, we've done that for years and years. But MI has a real different way of looking at this. What we talk about in MI instead is we talk about what we call the status quo or sustained talk.
Kristen just was disconnected. If you give her a couple minutes, she'll dial back in and continue the webinar.
Hello?
We hear you.
Sorry about that. I had a little failure on my phone here. So we're talking about, what I had talked before about change the status quo talk, and that often be incident resistance. Change talk is something different. Change talk is actually any reason, need, desire, or ability for somebody to change. So it is actually what we call preparatory change talk when we start to hear that. And often we have many opportunities to start to hear that particular change talk as people are being evocative. Eventually, we want to get to a place of commitment change talk, where people are actually telling us if they have any commitment, anything that we call activation or taking steps. And if you want to, commitment is when someone actually says, I will do this, I will stop doing this behavior, I will stop drinking. Activation is, I will try. I'll go ahead and go to that meeting. I'll check it out. I'll see if 12-step works for me. Taking steps might be something like, I'm actually cutting back on alcohol. I'm going to go ahead and maybe go from 6 drinks a day down to 5 drinks a day. I'll go ahead and get started. And that's actually a really important way to start to engage change. And so how do we do all this? And if we think about our processes, well, how do we actually move through the processes? Well, there's actually motivational interviewing techniques, and we call them our OARS, O-A-R-S. And in the most recent edition of motivational interviewing, we added providing information and advice. Okay, and any questions so far?
You can continue.
Continue? Okay. So what they do is this actually really builds a lot of the empathy and motivation, because this is how we become, using these particular interventions, this is how we actually become collaborative and engaging with somebody. Okay. What it does is these particular skills allow for a lot of opportunities for different ways of responding. And reflective listening, the R in OARS, is the core skill. What does it do? It provides accurate empathy that really helps people know that they've been heard. It makes a guess as to what somebody is saying, but it's a statement, not a question. So we're saying things like, so it sounds like you've had a lot of consequences from your drinking, as opposed to, so you've had a lot of consequences from your drinking? I mean, you can see the difference in how those two responses. One comes off as a real reflective statement of understanding, and one is unsure, maybe at best. And especially when you get a lot of those inflected statements, a lot of those questions, it really starts to become very difficult for someone to tolerate. Some of these reflections can be simple or complex. Sometimes if we're just doing a lot of simple reflections, like, oh, you feel sad, over and over again, they go in circles. But we can make some of these reflections more complex, and I think that's important. I think a lot of times people think these skills are just so simple they can't really do much. But actually, a lot of simplicity is really elegant, and people can make a lot of change. But they take some skill and practice in order to become really refined. What else do we have? Well, we have the open-ended questions. And the difference between open and closed is open actually allows for a broad latitude for how someone can respond. A closed question is much more, it's constrained, and it's just like yes, no, or a very specific answer. If you ask too many closed questions, you're going to get really stuck, and someone's very unmotivated very quickly. There's also an affirmation type of intervention that recognizes and supports and encourages someone's strengths and efforts. Keris is talking a lot about strength-based approaches as well as I, and there's this sense of we really want to be able to acknowledge somebody's achievements, their abilities, their attempts to do something, their awards. All of these will build strength and movement towards doing something different in their lives. Someone's feeling lack of hope, the most important thing they have is this reflection around some of their gifts. And then a summary, again, is organizing. It pulls things together, it links, it provides transitions. So if someone can be confused or not sure where to start, but it also kind of moves somebody along. It really helps when you're talking about a lot of material to hear it all come together and to link towards a logical changing spot. So again, just to give us a little chance to kind of look at some of these things, a reflection, I always like to spend some time on reflection no matter where I'm training or what I'm doing, because a reflection is in fact the most basic and most important in some ways. They're statements rather than questions, as I said before. They make a guess about what a client's meaning is as opposed to asking, and they yield more information and better understanding. Often, questions can be turned into reflections. Reflections can be simple. They can repeat an element of what a person says. It could be like, oh, that's so sad. Or, oh, you really had a big loss. I mean, just a little piece. Or just rephrasing, which is basically stating what somebody says but substitutes maybe some slightly different languaging or rephrases what was offered. But they can also be more complex, and I have right here just some simple reflection formats, which I got from Robert Karkoff, who did this work generations ago, some really important stuff. And if you are interested in looking at some of this, I give this to seasoned clinicians as well as my students, because even if people have been trained in like how to reflect, they forget how, and they really struggle, and they won't do it. They'll kind of go back to asking a lot of questions or giving a lot of advice when people don't want it, and that slows down motivation. It really makes people feel unmotivated. They don't hear themselves talk, for example. So I give people these very basic formats to practice with. You don't want this to be everything that you do all the time, or you're going to sound like a robot. But it's a great way to get started if you're not sure where to. So you feel really worried right now because you can't get to work when you don't have your license after the DUI. You feel really worried because you can't get to work and you'd like to, so you don't lose your house. So these things can actually really help us figure out how to do reflections. Any questions so far? Okay, seeing none, I'm going to continue. Reflections can also be more complex, and this is actually really where I think some of the very dynamic work in MI can come from. Just to give you ideas, there's paraphrasing, which is a little more advanced than the basic reflection. There's also, which is basically, we're inferring maybe a little more meaning. We're saying back in new words. It kind of extends what was said. Continuing the paragraph, the listener reflects what could be the speaker's next sentence instead of repeating the last sentence. So maybe someone's talking about their DUI and all the consequences, and I might add, oh, and that really made you feel angry. So it's kind of adding maybe a part that was unsaid. And then there's reflection of feeling. The listener paraphrases the emotional dimension of what was said using feeling words. So you're really angry right now. So this is really hurtful for you. Metaphor. Metaphor is a powerful way of stating a reflection that helps the client recognize his or her thoughts and feelings via comparison. So it's this idea of actually finding ways of giving some distance through a metaphor narrative. So it might be like, wow, being without your license feels like, being out to sea without a life jacket. You feel just really, lost and kind of unsafe, as an example. A double-sided reflection is really helpful in motivational interviewing because it reflects both sides of the conflict. So on the one hand, you really like to drink, but on the other hand, you have a lot of consequences from having multiple DUIs. And so I'm not necessarily telling people anything new, but I'm doing it in a way that's reflective, and again, it's inherently motivating. And then finally, there's amplified. Of course, there's more of these types of reflections, but these are the ones that are probably the most commonly used. An amplified reflection is strategically overshooting when someone is very much engaged in the status quo, and they don't want to move and are maybe even kind of, defensive, and they're not terribly flexible, or they're expecting us to really be too instructive, and they're kind of defending against that. So sometimes what we do is we strategically overshoot, and I may say something like, okay, so for you, drinking and driving, having DUIs, it's just really been no problem at all. It's absolutely, totally fine. Keep doing it forever. So when I say that, and again, I'm kind of exaggerating my response right now, so it might seem a little bit maybe more flipped than what I might actually do in a session, but sometimes that really gets somebody to back off, and they might say something like, well, actually, there has been times when it's been really hard. So now I have a little practice for us at this point, just for us to do really quickly about reforming reflections. And what you can do is, if you're in a room, you can actually do this with people in the room. You can practice, or you can just think of one if you're on the phone. I have 4 different responses here, or 4 different statements. You can pick one. You don't have to do them all. But you can just look at one here and respond to it in a reflection. You can type it in, or you can say it back to me. So I'll give you an example. I might do the first one. I've been depressed lately. I keep trying to keep trying things other than drinking to help myself feel better, but nothing seems to work except for having a couple of drinks. So I might say, wow, so for you, it's you've really tried to do other things to help yourself out, but at this point, really drinking seems to be the only thing that really helps out. So that's kind of a different way of paraphrasing or rephrasing what somebody has said. But I could also maybe do a double-sided reflection, So on the one hand, you're really, really depressed and you don't necessarily want to feel that way. And on the other hand, you find a little bit of relief when you're able to use some alcohol. So go ahead and give it a try, and we'll come back and check in with a couple of reflections that people might have used. Okay, do we have any?
No responses yet.
No responses yet?
No.
Okay. All right. Well, I'm going to go ahead and move along as people hopefully be able to think of some responses. Maybe during our question and answer period, we can double check to see if anybody has received any or came up with any. But that kind of practice is actually really helpful for folks to get a sense of how to actually interact with information without immediately giving advice or asking questions. Go back here. There we go. All right. Another thing we talk about, that open versus closed. As I said before, closed questions are short. They're yes or no, or very specific. What's your phone number? Sometimes we do multiple choices, like do you plan to quit, cut down, or keep drinking? Sometimes we have to do closed questions. I don't always ask somebody, tell me a few things about your phone number, right? I'm just going to ask them, what's your phone number? But a lot of times we do overuse them. So we want to ask fewer questions, and when we do, we want to make them more open. And what open-ended questions do is they open the door, they encourage someone to talk, they don't invite a short answer, and they leave a broader latitude for how to respond. So just some general guidelines. We want to ask fewer rather than more questions. Sometimes when I train a large group of people, I do an exercise called It'll Cost You. And I give people a bunch of change, like pennies and quarters. And what I do is I have them practice, and every time they give a reflection, they could put aside a penny. And every time they ask a question, they have to pay for it with one of the 4 quarters I give them. And what it does is it really makes people think very strategically about what questions are they asking, and not to ask more than 3 in a row. And they want to be able to ask more open than closed questions. One guideline for motivational interviewing that we often do is we ask people to offer 2 reflections for each question asked. So there's this idea of sandwiching our questions within reflections. So that way it becomes less jarring than to have one question after another, because what happens is people start to feel interrogated. And again, especially with substance use issues, people will shut down. All right, so affirmations. Affirmations, again, I think these are so essential to recovery. They're positive reframes. They emphasize a strength. They notice and appreciate a positive action. They're not just like compliments like, gee, that's so great, or how good of you, but they should be generous. I like this idea of they need to be specific and express a positive regard and caring, like, good luck on that job next week, job interview. And they strengthen our therapeutic relationship. They're really important in that particular regard. And I'll go back to affirmation for a second. I said before about affirmations being these positive reframes. One thing I advise people to do is when you affirm somebody is really try to think about something that's non-judgmental and not evaluative, that's really focusing on a behavior or something that somebody has some ability to control. So it might be like, well, I noticed you worked really hard on the share you had at that meeting. Or, I know you really don't want to be here today, and yet you really did what you needed to do to get down here, even though it was, something that was very challenging. And these affirmations, what they do is they really positively reinforce what we want people to be doing. And by doing that, it really helps train people to, or I should say, it trains people to be acting good. The idea we do with little kids, like catch them being good, that's what we're doing with adults. I mention this in particular is because I've noticed from my experience working in both mental health and substance abuse settings that affirmations are often underused, and they are so important. I've had a lot of people who basically go through life feeling very kind of maybe beat down and not always greatly supported and really hopeless. And affirmations are they are injections of hope. They give people so much more strength, and that is intensely motivating. So really use affirmations, I'm always telling people. And then look at summaries. Summaries really help to outline the dominant themes, and boy, that really helps people out. So much of lack of motivation is just not knowing where to begin. So we ask people to be brief, to be selective, because sometimes when people are training, they have a tendency to, really overdo a summary and be very long-winded, and people can sometimes lose focus. So think about, what are some of the main pieces of this? And we don't want to just focus on change talks, because sometimes when we do that, we move too quickly, and then people will back off towards change. So in my DUI example, if I just start talking about all the good things that are going to happen when somebody changes, or all the bad things about drinking, if I do that too soon without supporting some of their reasons that they drank to begin with, then sometimes people can seem unmotivated or back off. Here's the final thing that's kind of new in our whole field of motivational interviewing, it's actually really thinking in a very mindful, conscious way of how do we give advice or information. It used to be, or there was a thought, that in motivational interviewing we don't advise people at all. You know, it's just so purely client-centered that we don't want to get caught up in advice. But people want advice a lot of times, especially I think people from different cultures, different age groups. Some people come in really wanting to be instructed. So what we do here is we do advice in a way that our information that is actually motivating or more motivating. And we use this model we call EPE. And basically, it's the E can also be thought of as asking. The first one is we ask permission to give advice or information. I have some thoughts about treatment programs that you might want to consider. Would you like to hear those? Provide is we provide the advice or the information in a chunk that somebody can tolerate. We don't want to go on, but a couple of sentences or very specific pieces of advice or a couple of options for advice is really helpful. We don't want to say something, oh, you really want to do this, you know, but we maybe give them a couple of options. Well, you might want to consider X, Y, and Z, and to be clear and to really prioritize those things that we think really fit for that person. And then finally, we elicit. And what we're eliciting is feedback from the client. And so it's a very boundaried and respectful and non-presumptive approach. It's not like, I have this advice or information and you're going to take it for it. It's more like, I have some thoughts, you might find them useful. We're almost done with a lot of the main questions or ideas that I have here. But are there any questions at this moment about any of the 4 skills, and the EPE, PC, the ORS Plus?
There's no questions about the...
No questions?
Yeah.
Thank you. Okay. So there's something that we have in motivational interviewing that when we're working with somebody and it's really working and it's really moving and it feels really good, we call that dancing. And that when we're in a place where people are not motivated and they're really struggling and there's a real difficulty and a real challenge, we call that wrestling. And a lot of times in our training, we'll actually refer to something that we very cutely call the dancing versus wrestling scale. And we actually have our students, you know, people practicing, listening to various vignettes, or as they practice with each other, rate it on the dancing wrestling scale. You know, a scale of 1 to 10, how did it feel in terms of dancing? Were you really dancing or not dancing at all? You know, were you, you know, wrestling or not at all? And so where are you there? So there's certain traps, certain things that we do that can make us wrestle and that are not in the spirit of MI. And I mention them here because these traps have been really major in the whole field of addictions counseling, for instance. We used to get into these traps all the time, and that's why we call people resistant and difficult and all these other things. One is the question-answer trap, which is as a counselor, we ask way too many questions, and the client just passively provides answers. And after a while, people really shut down. This is big when you're counseling teenagers as well. They expect just to be asked a lot of questions, and they shut down. Taking sides trap, which is we focus only on one side of the ambivalence. So I might say, oh, well, I'm glad you're here. There's so many good reasons for you to quit drinking or using. And we just start focusing on that. And if somebody's ambivalent, they will start, it's very unconscious a lot of times, defending that, yeah, but, you know, drinking's helped me relax and it helps me in social settings. We have to just be balanced and to, again, to accept that. The expert trap, that one comes up, again, I'm thinking of Keris' slide, that we start to lecture to the client because I know better and I'm the expert. And if someone comes to us and they think, well, you're the expert and I want your help expert, that's different. Then they're giving us permission and they're requesting, and we want to give them whatever information we have. But when we impose that without asking the EPE, that's where we get into the trap. There's also the labeling trap, which is you need to take on a label or give a premature diagnosis. And that can happen certainly in any kind of counseling situation where someone might say, well, clearly you're an alcoholic, or you're this or that, you're an addict. And this is actually why a lot of people really struggle with 12-step. Because what's one of the things you have to do when you go to a 12-step meeting? You know, you go in and you say, hi, I'm Kristen, I'm an alcoholic. And for somebody who's ambivalent, that puts them right out the door. Now, I think 12-step is terrific, and it's so accessible. But as far as motivational in some ways, if someone's not in action, it might not fit. It might be too soon. There's the blaming trap, like finding out who's responsible. And there's been a trend in addictions for people to have to take responsibility. You need to be responsible for your addiction. And on some level, of course, that's true. But, you know, first of all, it's already implied. They're there. They're in the room. To blame someone actually can just really be a setback because people start to feel shame. And then shame in and of itself is counter to hope. And that slows things down. And it makes people wrestle. There's the pouncing trap. And that's like, aha, I got you. So maybe I'm working with someone for a while, and they say, you know what, Kristen, I think I do want a list of those meetings. I think I want to check them out. I have to, it's like with kids, I have to make sure not to get too excited about, oh, so good, I'm so glad you're here, you finally got it, welcome. You know, I want to avoid that because that can make people back on their heels too. Let me back off. There's also the information overload, which you might be feeling from me right about now. But that is when we give too much advice or information. Even if people want to hear it, at some point they just can't take it in. That's with the EPE, why we just give little pieces. And then finally, there's premature action trap. That's when you get somebody to agree to do something before they're ready. We get to that planning stage too soon. Like, great, so you want to start treatment. Well, wonderful, let's go tomorrow. And then they don't come back or they don't follow through, and it's like, oh, they didn't want it. Well, actually, maybe they did very much, but it was just too much too soon. So those are our traps, and we see them a lot in addiction. Finally, I know it's actually kind of a good time in here. I know at 12 o'clock we're taking some questions, so I just want to direct your attention to literature. These are some of my absolute favorites. Motivational interviewing, preparing people for change. That's what pretty much everything I've been talking about has been based on, although I threw in a few things here from David Rosengren's book at the bottom, Building Motivational Interviewing Skills. That's a nice workbook, has some good practice pieces. And these other ones are just really nice pieces. The health behavior change, Steve Rolnick, is for people working in primary care settings and can be very helpful if you're doing integrated care. And then the group treatment book for substance abuse is the bottom. It's hugely useful as a place to get started. It's kind of been a real go-to book for a lot of people getting started, whether or not they're doing groups or working with substance abuse. It really helps people get organized. And then I have websites. These are some of my favorites, and the reason I really like them is they have all kinds of free guides and information. Motivational interviewing is a real sweetheart of the evidence-based practices and protocols field because it's been so well researched, and the results have been so promising and effective in so many ways. And because of that, because of this great research base, there are all these tools that were developed over the last 20, 25, 30 years, and they end up getting posted, and they get posted and disseminated on a number of these sites, especially the top one and the bottom one. The top one, of course, is the website, and actually the Mid-Atlantic Technology Center, they have their stuff at site now, but they were organizing and helping host the motivational interviewing site for many years. But there's a great resources there. There's also CASA, which is the substance abuse treatment program at University of New Mexico, where Dr. Miller worked, I should say. And all of his graduate students over the years who did all this terrific research created all these tools. There's assessment tools. There's, tools to be very evocative, to start conversations. A bunch in Spanish. Worked a lot with the Latino population in New Mexico, as well as a number of tribal populations, and have had great results and great tools. So that's posted. And then SAMHSA, because motivational interviewing is used so effectively in substance use treatment, has a number of guides that are based on various aspects of motivational interviewing that they've put together over the last couple of decades as well. So I believe that is the end of my particular share. I would love to help entertain some questions at this point in the webinar.
Yes.
And I thank you very much.
Kristen, Janet actually has a question, well, a comment. She said, our
Alrighty.
course has had a presentation on motivational interviewing. This is a great presentation because it shows how the nuances of the methods. I am curious to ask how our county has facilitated the training and whether they have ways of updating and fine-tuning their skills.
Okay, and that last part was just for if in your county, if people have been obtaining the training and how people can update their skills.
Yes.
Make sure I got that correct. There's a number of kind of resources out there in terms of kind of like certainly training centers and training individuals and folks. And what I've done over time is, you go into a county, you provide a training, and you go and you put it out there, and then you just hope that people are going to be doing it and they'll follow up. I always really encourage anybody at the trainings to find their champions, the people who work in their, maybe the main supervisors, or you can even call together a group of people really interested in this approach to really help them think about how they can do like little coaching teams, but even supervisors. And I've done this with people working with youth teams as well as adult teams, older adult teams, transitional age youth teams. They can actually take some of these things I've been talking about in terms of skill sets and just put aside some time each week. Maybe it's at their staff meeting. They spend 5 to 10 minutes on a very bustling agenda that we all have. They spend 10 minutes in dyads practicing complex reflections. They spend next week 10 minutes coming up with affirmations that they could use with their clients. So what's happening is that each week there's a little bit of practice, and it does a world of good. I mean, it's great when we can get teams of people are practicing every week, and they record themselves, and they code their responses, and they send them to a person, like myself or other trained people to review them and to give them feedback. I mean, that stuff is terrific. But a lot of times in public settings, we just too busy. So those small, kind of discrete practice sessions can be very, very helpful. And then these websites can be really helpful because they're posting videos and more videos, and YouTube is coming up with more stuff. And there's another place that's also providing stuff, the change companies. So it's changecompanies.net. And they're starting to provide, I'll type that in a second, they're starting to provide a lot of video training as well. So in counties, you can go out, you can spend a couple $100 getting some of these videos, and a lot of them are streaming, so you could have a whole bunch of sites being able to watch them. We're getting more and more technology to really help people learn and to keep their skills up. That was a long response.
Are there any other questions? I have a question about motivational interviewing and stages of change, for example. Can you use this same technique when you bump into folks within systems who are trying to do change within their system or their agency or their department or their program, and they have folks who are resistant to change? Can you use sort of the same techniques So it's not in a treatment setting. It's not in a harm reduction setting. It's just using a quote-unquote, I would say maybe a therapeutic technique. I don't know if you want to call motivational interviewing therapeutic or not, but so can you use it in an organizational setting?
Pretty much that's kind of the way I function every day.
Okay.
Because as you get to do this and do it, a lot, it becomes kind of a way of working. Absolutely. And it actually helps for supervisors to reduce a lot of frustration. And people organizing programs, and when you bring people together in groups to collaborate and to problem solve and to figure things out, it's so similar. You have people who are so gung-ho and want to change, and you have some who are in that middle place, I'm not sure, but they're watching the people who want to change, so they can be brought along. And then you have your people who just, I don't want it, I'm just not going to. And clearly with motivational interviewing in individual clinical practice as well as in a change systems practice, if you have somebody who's just like has a really bad case of the I don't want it and I'm not going to, and they're just, what they're motivated towards is really not doing anything. I mean, it doesn't solve all problems. Although, I find with people like that, if I just kind of find some way of continuing to help them be engaged in a way that's reasonable for all of us, then sometimes they actually come along just because it's so much about their own autonomy. But I do the same thing with people in like an organizational situation. I'm always trying to ask, well, what's their motivation? What brings them here? Why are they sitting at this meeting? What is it from their perspective? And to the extent that I can start to integrate their needs and what they'd like into the larger perspective, I do that. And so, they can be happy too in terms of being part of the process. So it's the same thing I'm using in that process as individual therapy. If somebody feels like they're wrestling with me, it's because we're out of sync. We're really out of sync. So what I want to do is I want to be able to figure out how do I get in sync with this person, this individual, or this system. Did I answer your question?
Yes, thank you.
And I use the same skills. I use active, the reflection. I'll make it from a point of view. Yeah, the oars, yeah. Yeah, absolutely.
Okay. And Kristen, a personal note from Kelly, she said, thank you for reinforcing what I learned in my interviewing technique classes.
Oh, excellent. Okay, great. Great. Yeah, what's funny about that, I just got to say this, that I'm always, interns and students love to hear this. Older clinicians, I say older in terms of time in the field, not so much. But a lot of times when I'm working with like students, interns, trainees, they get this. They haven't been so far down their clinical training path that they're kind of, they're still kind of new to being in clinical situations, and they're new to learning some of these skills because a lot of these are just very, very basic things that people learn in their practicum courses. And so it's fun for them to be feeling really accomplished and to get a lot of affirmation about their skills right away. Sometimes it's the people who've been really practicing in the older models and the kind of medical models that really sometimes have the most challenge, especially around the spirit, especially around just being with people.
Okay, I don't think we have any more questions or comments. Is that right, Camille?
No.
Okay. So with that, we're at the end of our time, and I would like to thank all of you in the audience for attending. Once again, we encourage you to take a few moments to share your feedback as you exit this session. And if you haven't yet, please let us know if you're interested in receiving CEUs for participating in today's webinar. So with that, I want to thank everyone, and we will conclude the broadcast. And thank you again for joining us.